the couple of important stuff. All right. So before that, I would like to ask that how many of you guys are appearing in January exam, and where do you guys see yourself in terms of preparation and all? If you guys have any query in terms of the preparation, in terms of that what to do in the last 1.5 month or so. So in fact, yes, it is to be exact, it is 1.5 month, right? So if any one of you have any query regarding exam, regarding this preparation, how to utilize this time, how to cope up with the stress as well, so you guys can ask me anytime. All right. So I can see so many familiar names, familiar faces, and I'm so happy and so glad to connect with you all after a long time. So Anisha is here, Rabia, Saira, Dr. Anjum, Hina, Saud, Farhad, Lina, Roma. I hope all of you guys, and Noor Afshan, if I'm not wrong. So I hope everyone is doing good, and Hina as well. So so many people are joining in, so I would just wait for another 1 or 2 minutes. And before that, I would like to the ask from any one of you, if you have any query in terms of preparation or anything, you guys can ask me. All right, and then we will formally start our session. Okay, so we do have a okay here, Abhya, always there, always there. Okay, so I really want, the all of you to study hard. Always remember there is no shortcut to success. All right. So if you guys look at my, the portfolio, so of course I have worked day and night. Okay. I have worked hard to achieve all these, the boards and everything. So it has never been an easy ride. All right. So I had to sacrifice a lot of stuff. I had to study hard. I had to, the hard work. All right. So never think that, the success comes like, like this, just like this. Okay. You have to work hard. You have to work smart, in fact. Okay. And of course, you have to sacrifice a lot of stuff. Not in terms of, what you can say, financial. Okay. That is one of the aspect, but moreover, this is like you are dedicating your time, you are giving your, the precious energy. Maybe you are sacrificing your own, the stuff, okay, your leisure time, or maybe, this, of course, partly, our family suffers as well. Because if we are indulged in our studies and we are not giving, the much time to our family, so they do sacrifice as well. So what I believe strongly and personally, that all of these exams require a lot of sacrifices. Okay. So, but in the end, if the result is good and, then, it's all okay. If end is well, all is well, isn't it? So do study hard. All right. And always remember there is no shortcut. Don't look at others, what others are doing and where anyone is standing in their own life. You have not the fought their battle. They don't know what you are going through. All right. So just the sail through, just sail through. Okay, don't stop. And just the thinking to stop when you think you are done. And for me personally, we don't have any limit. We all doctors are limitless, right? So one after one, we would be the into something. Like for me, I have not stopped over here with these the boards and all. So I am trying to the improve on myself. Now I am the theoretically I'm strong, so now I am the trying to improve on my clinical skills as well. All right. So of course, the having said that, the of course, it does give you a clear idea how are you going to become a good clinician. Okay, so in the end, everybody wants to become a good doctor. Apart from the a kind of hinge that okay, you have to move to UK or Ireland or any other country. Okay, but deep down, we all really want to become a good clinician or a good doctor and to serve our community, isn't it? So whenever you study, whenever you think about something, always think of that how I can be fruitful to my community. How can I be a good doctor? How can I be remembered as a good person or individual as well? All right. So with this positive note, we are going to start our session and we are going to discuss a very important talk article, which I personally found very interesting while I was, trying to summarize, the all talks. So this talk article was kind of, the very good in terms of that, we do deal with certain women in the postpartum phase in which we have to decide for any kind of therapy. And somehow, we get confused that which therapy to choose, what to give, what should be the dosage, whether it is, the breastfeeding friendly or no, and where we have to stop and which medications are not to be recommended at all. All right. So with this, the exam series webinar, because I have planned to conduct, the couple of webinars before exam, because lately I was absent because of my own, the personal, the reasons. But now I'm back, and because I do get several messages on daily basis that we really want, the couple of webinars, couple of, the sessions in which, anyone can talk to me freely. And of course, these are all free webinars. So all of you guys are welcome to attend, to join, and to discuss. And of course, the raise your queries or concerns if you have any. I would like to, the answer with the best of my knowledge wherever possible. All right. So let's get started. So today we are going to discuss the use of psychotropic medications in the perinatal period. This is relatively a new talk article released in July 2024. That makes that okay. From here, one or two questions might come in January exam, all right? Because this is almost 6 months before the due exam date. All right. So what I believe is that, okay, we can get one or two question out of this, although we already know a couple of things. But yes, when we do get any proper, the topic to discuss or topic to study from, so of course, then it has some kind of weightage. All right. So what do we, think of that pregnancy itself is not protective against mental illness. All right. We all know that pregnancy put a lot of mental stress or mental toll to certain women, certain age group as well, in which they are, the overwhelmed. They do think that, okay, they cannot bear the stress of being pregnant, or even, the after pregnancy, they can't cope up with the stress. Okay. So we do see a couple of, the mental health issues later on. Baby blues is very common. Okay. If it is not treated, then it can convert into PPD or postpartum depression, and the most severe form of mental illness, which is psychosis, isn't it? So if anybody who has had, any kind of, the background of having any mental illness, so yes, that is going to put the woman on extra burden or extra mental stress. All right. So talk article says that pregnancy is not protective against mental illness, and 10 to 20% of the women will experience a mental health problem antenatally or in the first year postpartum. I have observed a lot of, the women dealing with this particular, the challenge that, okay, I cannot be a good mother. Okay. I cannot fulfill the responsibility of being mother. I think I cannot cope up with the stress of raising a child. All right. So there are certain women, who do go through this thing. All right. So if we think that, if anybody who is dealing with this, the kind of issue while we are booking any woman at the time of booking, and the booking is almost like 8 to 10 weeks, isn't it? That is the ideal time of antenatal booking. So if you feel, that's why it is mandatory that now in the history you have to inquire about mental health question as well. Okay, so now this has been a trend, or you can say that this has been a pattern of taking history in NHS and Ireland as well, that you have to inquire about, at least you have to screen by asking 2 or 3 simple questions. And what are those questions? Number one, how have you been feeling for the last 4 weeks? Okay. So it might give you a clue that someone is going through something and you have to pick it. All right. And then if the answer is yes, okay, note it down, then you can simply ask that, do you feel depressed or down, or the having lack of interest in doing things in the last 4 weeks? All right. Because last 4 weeks is going to be a very the crucial time. Okay, perhaps she has been the going through, perhaps she still is going through, so she will open up if it is a recent event, right? So that's why the history is very much important. Okay, so if a person is having a background, the issue of having any of the mental health issues prior to conception, then yes, it would be in her history. And while you are going to book, the patient, or if a patient is a known case and on any kind of, the medications, she will eventually come to you because now they say, and now they, according to MBRA's report, now they say that, the preconception counseling is mandatory for any woman with any medical disorder. And by rule, preconception counseling would be 3 months prior to get pregnant. That's why they use the terminology these days, which is planned pregnancy. Okay, so this also we do ask in our history, is it a planned pregnancy or is it an unplanned pregnancy? All right, so if it is a planned pregnancy, then eventually you will come to know as a doctor that yes, she has had any pre-pregnancy counseling, and then she has ended up into being pregnant. Okay, so now the chart says that you should follow general principle if you have to manage psychiatric medication around pregnancy. If she is a known case, so preconception planning is a key, all right? And the aim for conception at the time of mental health stability, you will do the counseling, okay? Individualize the counseling, okay? If you can't do it, take help from psychological counselor. All right. If she is on any kind of drug, always think that if it is pregnancy friendly, if it is baby friendly or no, defer to the appropriate team, maximize non-pharmacological intervention, right? And what is that non-pharmacological? Psychotherapy, social support, occupational therapy, if at all needed. Discuss risk. Timing of the exposure matters, right? We all know that first trimester or up to 9 to 10 weeks is a kind of crucial time when organogenesis is there, when the many drugs can come into action and cause problems to the upcoming baby, isn't it? So it is important. Third trimester, the exposure may influence fetal growth and cause neonatal side effect as well. All right, and then you have to think about that do not stop medication suddenly. All right, every woman has some kind of a threshold, and in fact all these antipsychiatric or antipsychotic or antidepressant or anything, if you will stop them immediately, what the patient will get is a withdrawal, right? And that withdrawal can also be dangerous. All right, so that the decision to stop the medications should be the made along with the lines of the guidelines, along with the the kind of discussion with the psychiatrist or psychologist or counselor if they have started it earlier. So avoid subtherapeutic doses of medications, use a collaborative multidisciplinary team approach, and breastfeeding should also be discussed and encouraged, of course. All right, because every child, every baby has the a right to have a breastfeeding, isn't it? But of course you have to evaluate, then you have to think of that, okay, if this drug is the okay to be used in the pregnancy and breastfeeding later on or no. All right, so preconception care is very important. Then we do have the certain classes of drugs, isn't it, what we do use in the the perinatal phase. All right, the first of all, you need to understand what are the common psychological or psychiatric disorders do we see in our community, okay, or in our the set of patients, right? So the first is depression, second is anxiety, right? And the third is going to be, if it is a severe form, then OCD, okay? Then it can be, even if it is more severe, then yes, it is going to be more psychosomatic disorders, right? Schizophrenia, then there can be any sleep disturbance disorders, then there can be anything, right? So there can be a couple of, the disorders which do require input in terms of in the pregnancy antenatal phase as well as in the postpartum phase as well. So if we talk about antidepressants, so of course we are going to be dealing with depression first, right? So it is very much common around the perinatal period, which affects 12% of the women antenatally. However, it affects more in the postnatal period. And the reason being, yes, not only the physical changes, not only the hormonal changes, but yes, of course, the feeling of being, the overwhelmed, okay, feeling of being, the inadequate, maybe inadequacy, that I can't be a good mother or something like that, okay? If at all somebody has had any kind of background risk of any bipolar disorder or family history of bipolar disorder as well, then yes, this lady would be at a more high risk of development of this certain type of depression and anxiety or anything. Right? 47% of the clinicians will discontinue the medication. So it is imperative that everyone should be aware of all antidepressants and their effects. That's why they say that MDT input is mandatory, right? So the first, the set of or the first class of antidepressant which is widely used is SSRI, isn't it? So SSRI is what? Selective serotonin reuptake inhibitors. And what does serotonin do in our, the body? Generally speaking, it is termed as a happy, the neurotransmitter, which is going to bring the happiness or, the what you can say, the feeling of being, the adequate or anything. All right. So they generally, they all these, the neurotransmitters are going to be degraded at the nerve endings. So by giving SSRI, what we are going to do is that we are not going to, the block, or we are not going to degrade all these, the neurotransmitters. So selective serotonin reuptake inhibitors, right? So SSRI we will use, and the example of the SSRI is fluoxetine, sertraline, and citalopram or escitalopram, right? So if you will discontinue, the symptoms will relapse if it is stopped abruptly. That's why gradual stoppage is mandatory and it is recommended. So possible association with the cardiac malformation, however, absolute risk remains small. And then PNAS is up to 30%, and the background risk is almost 10%. Okay. And postnatal, the persistent pulmonary hypertension, okay, that is also there. And we will read it in bit more detail. Okay. So what else do we need to do with all these drugs is that we would be very careful for any congenital malformation associated with all these antidepressants. Although fluoxetine is termed as a relatively safe drug to be used throughout pregnancy as well as postpartum phase as well, right? However, sertraline, citalopram, sometimes we do not use, okay? Or even if we have to use it, then it should be along with the lines of, the guidelines, and after having thorough discussion with the woman, her caregiver, and also the clinician as well. All right. And plus the second set of, the antidepressant is SNRI, right? Selective, the norepinephrine reuptake inhibitors. And then we do have, the NASSAS, NASAs. Then we do have tricyclic antidepressants as well. So like, the every drug, we will be, reading all these drugs one by one. So don't be upset. All right. So every drug has some pros and every drug has some cons. Like we always have read that, okay, every effect has a side effect as well. Okay. But yes, we have to outweigh the risk and balance if we have to deal with the pregnant individual, isn't it? SSRI. So we would be talking about teratogenicity. We would be talking about pregnancy outcome as well. So as the till date, or after having a series of studies, they did not find any kind of congenital malformations or congenital abnormality, okay, with the in utero SSRI exposure. Older studies have reported various association, but not the new studies or the new series of the studies. Paroxetine, which appeared to increase the rate of cardiac defects to 2% from a background risk of 1%. The overall consensus is that if an increased risk of congenital malformation does exist, it is likely to be small in the context of antidepressant monotherapy. And I'm sure you guys also know this, that monotherapy would be always preferred and it would not be associated with such harm. And of course, it is not going to cause multiple congenital malformations, unlike polytherapy, right? Polytherapy is always dangerous. What about pregnancy outcome? So its exposure is not associated with an increased risk of miscarriage, stillbirth, or neonatal death. Meta-analysis has shown that there can be small increase in the preterm birth rate independent of the baseline level of depression. But this is unlikely to have a clinical significance, right? So serotonergic drug impair platelet aggregation and are also associated with increased bleeding risk. SSRI use in the final month of pregnancy is associated with increased risk of PPH. This could be a small, the risk. For the exam perspective, yes, you need to remember this, okay? That it can impair platelet aggregation, and yes, it can increases the bleeding risk. So yes, in turn, it can increases the chance of having PPH. Then what about neonatal and developmental problem? So poor neonatal adaptation syndrome, PNAS, okay, is seen in 10% of all newborns and in up to 30% of those exposed to antidepressant medications. So this poor neonatal adaptation syndrome can present with a range of symptoms including irritability, jitteriness, feeding, or sleeping difficulties. Okay, in the majority of the cases, these symptoms are mild and self-limiting to a few days. PNAS may be more clinically relevant if there has been exposure to multiple psychotropic drugs and in pregnancies complicated by growth restriction, prematurity, and congenital anomaly. Okay, having said that, it does not mean that these antidepressants would be associated with this. For example, if a lady has had, the anicomobs, so yeah, the chances of having, the aggravation of the symptoms can be there. So serotogenic antidepressant exposure is also associated with persistent pulmonary hypertension of the newborn, PPHN, in which pulmonary vascular resistance fails to decrease at birth, leading to hypoxia. And the incidence is 2 by 1,000 in the general population, so it will increase up to 3 in 1,000 for the infants who have been exposed to antidepressant. Antidepressant exposure in pregnancy is not associated with increased risk of autism. So this is important to note because these days autism is there. Okay, we do see many babies with the autism, isn't it? From the mild degree to the severe form. Childhood behavioral problems as well. There is growing evidence that untreated maternal depression may increases these risks, of course. So what about breastfeeding for the antidepressants? Yeah, they can be used safely in the breastfeeding, and the transient adverse effects such as colic or drowsiness have been reported. However, longitudinal studies have not identified any neurodevelopmental concerns. This is a form of the antidepressant, sertraline, which is associated with the lowest excretion risk in the breast milk and is often the medication of choice in antidepressant naive women. Okay, it means that we can use it but not paroxetine. Okay, paroxetine is bit, uh, associated with some side effects. If there has been a previous positive response to a different antidepressant, however, continuing or reinstating this agent is usually recommended. So usually what we do is, as a rule, that if any woman is a known case of anything, or if she is on any kind of certain medications for any medical illness whatsoever, so in the pregnancy, we will modulate the medications. Post-pregnancy, we might, ask them to continue the pre-pregnancy medications, isn't it? So this is how the maternal medicine disorders rule goes. Okay, so post-pregnancy, we will start her on pre-pregnancy, the any medication. Okay, keeping in view of the breastfeeding, keeping in view of the, the risk to the neonate as well. All right, clear for antidepressant, everyone? Any question? Everybody is so quiet. So I don't know what is happening. Is everything clear, guys? Say something. Till now it's clear. Okay, brilliant. Good job. Thank you. All right, so we are done with antidepressants, all right? And now we will move on to the another set of medications, what we do use in the perinatal period, which is SNRI, right? And which is SNRI? Serotonin, norepinephrine reuptake inhibitors. Okay, noradrenaline, most commonly used, and specific serotonergic antidepressant, NASA, such as mirtazapine, which has additional benefits as an antiemetic and appetite stimulant. So write it down because I think this could be one of our question. It has been used successfully in the management of hyperemesis gravidarum, but where? We don't know. Okay. So, but yes, for theoretical purpose, you should know that, okay, this could be one of the, the antiemetic as well. Exposure in pregnancy is not associated with major congenital abnormalities or pregnancy loss. However, mirtazapine is associated with weight gain and insulin resistance. Okay, and use in pregnancy may increase the risk of gestational diabetes. and it has not been associated with adverse effects in breastfed infants, although its sedating effect may be barrier to the nighttime feeding as well, of course, because if a mother is sleeping at night, and of course she can't be up to breastfeed her baby, isn't it? So this could be, the one of the reason. So point to note from SNRI is mirtazapine, which can be appetite stimulant or antiemetic. All right, it is associated with weight gain and insulin resistance, and hence it will pose the woman to the gestational diabetes. All right, and also, the sedating effects are there as well. Okay, so these 3 to 4 properties needs to be remembered. Then what about tricyclic antidepressants? Although it is relatively uncommon due to its anticholinergic effects and risk of cardiotoxicity in overdose, TCAS may be helpful. However, in cases of comorbid chronic pain, there is no evidence that TCA increases the risk of congenital malformation. Okay, there may be a high risk of the PNAS with third trimester TCA exposure. Okay, then serotonergic antidepressants and TCA use in the breastfeeding as well. So sometimes it can be associated with neonatal sedation. So that's why, we need to be, the very careful. PNAS, we have just read PNAS, sweetheart. PNAS what? Poor neonatal adaptation syndrome. Okay? Clear, Aisha? Poor neonatal adaptation syndrome.
Okay, Jazakallah.
Okay, brilliant. So mood stabilizers. Yes, we also need mood stabilizers, isn't it? We don't want to study, aaj mood nahi hai, we don't want to study at all, right? So mood stabilizer, a side joke. So yes, it is also important. It is used in the bipolar or schizoaffective disorders as well, which are both associated with high rates of perinatal relapse, because postpartum phase is a very vulnerable phase. Okay, like I said earlier, that many women, they might not handle the postpartum phase. Okay, keeping in view that they are not ready to take the responsibility of being mother. They get overwhelmed, they get sometimes the moody or depressed. All right, and we do see baby blues quite often, isn't it? And if we overlook the baby blues, it can convert into depression. Even today in my clinic, I have seen one lady. She has had the birth 6 years ago, and she has had that the traumatic birth. Okay, prolonged labor followed by cesarean section, and she was so traumatized till today that now she doesn't want to become pregnant again. Now she thinks that, she doesn't have any kind of energy to become a mother, because she thinks that she is not a good mother. Feeling of inadequacy is there. And this happens, of course, when the postpartum depression is overlooked. So, of course, it will convert into a clinical depression later on. Okay, so being the clinician or being an OBG, trust me, if we try to the look at our patients, and if we try to the look at the all these symptoms quite the closely, things are going to be very easy for us and for the woman in the long run as well. Okay, so our take home message should be from today's session that don't overlook any symptom in the postpartum the phase. Try talking to them. Try the giving them education in the antenatal period as well, because 9 months is a good time. Okay, good, the long period of time in which you can prepare the woman for that. Okay, you are going to have additional responsibility. You might not sleep properly, you might not eat properly, but you don't need to get overwhelmed because of that. Okay, and you need to understand that you are becoming a mother now, and you have to take care of a baby. Okay, so all these things should be done antenatally, and the unluckily, our society, I mean, does not want to talk about the mental health. Everybody wants to look at physical health, isn't it? For me, mental health is equally important as well as physical health. Sometimes, the like I have told you today that she has been dealing with this, the feeling of inadequacy for the last 6 years. The patient I have seen today. Okay, and I was feeling so bad at that time, that what if her depression or the baby blues were caught in the immediate postpartum phase. So she wouldn't have been that vulnerable, she wouldn't have been the losing the charm in her life. Okay, she wouldn't have been the losing the interest in her life, isn't it? So of course I had to put her on the low dose citalopram or escitalopram, because at the moment she's not the pregnant. But yes, It is kind of sad. Okay. So for all of you guys, OPG, I'm sure you guys are wonderful doctors, and I would suggest to all of you that do talk to your patients. Okay, and do talk about all these four, the screening questions as well at the time of, the booking, at the time of history. If at all you feel that there is any kind of risk factor, okay, or if you want to take any help from your fellow colleague, okay, say a psychologist or psychosexual counselor and anyone, so don't hesitate, okay. Do try to counsel the woman that, okay, talking to someone, taking therapy is not bad, okay. Talking to someone in terms of that to feel and to get better is not bad, okay. Unlike in our society in which we think that, okay, if we will go to any, the therapy, so we will be called with names and all and blah blah blah. So do try to talk to your the patients as well. Okay, so yes, coming back to this, that mood stabilizer is the third form of drugs which do we use in the antenatal, perinatal, and postnatal period as well. So most of the time we do use them for bipolar and schizoaffective disorders. Sometimes because in the perinatal relapse is very high, okay, for the bipolar and schizoaffective disorder. And trust me, I have seen patients, the ending up in having, this severe psychosis, where they do really want to harm themselves as well as to their baby as well. Okay, so this really needs to be, the taken care of at, the earliest. So other medications include recurrent depression, behavioral disturbances in people with intellectual disabilities, and puerperal psychosis as well. Off-license prescriptions can sometimes used to treat affective instability in patients with complex trauma and personality disorders. Okay, the available, the data for the mood stabilizers is primarily derived from their use in epilepsy, which is independently associated with adverse obstetrical outcome. Okay, and caution is advised when we do apply all these findings to the perinatal population. So what are the mood stabilizers do we see? Lithium, most commonly used drugs, isn't it? And we will read lithium in bit more depth. Then anti-epileptic, we do use sodium valproate, carbamazepine, lamotrigine. Although they are anti-epileptic, but they do have all these, the kind of effects where they can work as a mood stabilizers as well. Okay, so we will read all of them one by one, and then we will see that what could be the potential exam question, because lithium has always been a favorite, the exam questions for MRCOG as well as MRCPI, okay, exams. So yeah, we will be talking about a bit more in detail for the lithium. So lithium is what? It is used to treat for the mania, mixed affective disorders, and depressive episodes. Plus, it is also used for long-term relapse prevention, and it is known to reduce the incidence of attempted and contemplated suicide. So lithium diffuses freely across the placenta, and concentrations are equilibrated between maternal and the fetal circulation. This means that use in pregnancy results in considerable fetal exposure, right? So what are going to be the side effects? I'm sure we all know and we all have heard about Epstein anomaly, right? So Epstein anomaly is going to be there, but this is not the only cardiac anomaly do we see in the the lithium affected individual. All right, cardiac defects can be there, 2 per 100 births compared with the 1 per 100 in the general population, means 2% from the baseline 1%. It is increased, isn't it? So women who continue lithium in pregnancy have comparable rates of the complications to women who discontinue lithium prior to pregnancy. So possible association between lithium exposure and increased fetal growths have been reported. So it can also cause nephrogenic diabetes insipidus in the mother, resulting in fetal polyuria and polyhydramnios. For these reasons, fetal growth and Liker volume monitoring is recommended. So just to summarize this, what the author wants to say is that if a woman is on lithium, usually we do try to switch the lithium towards any the pregnancy friendly medications. However, if we don't have any choice and if we really want to continue the lithium for any of these the mental health disorders, so what will happen is that we have to perform serial growth scans for the baby, all right, and we have to do the fetal biometry as well, and we have to look for Liker volume as well. All right, so if we have seen if we are seeing any patients in our clinic who is on lithium, all right. So what do you understand from this is that, okay, now I have to be very vigilant and very careful for the baby's growth, the liquor volume, as well as, because if there is polyhydramnios, the chances of iatrogenic preterm birth can also be there. Okay. Or even spontaneous preterm birth can also be there. All right. So it is very much important. Then antenatal and intrapartum monitoring. This is the RCOG favorite exam question. Why? Because lithium has a narrow therapeutic window because the toxicity level will be, the very high. Okay, if we don't monitor it, if we don't give a proper dose, then yes, there can be a toxicity. So serum levels more than 1.2 millimoles with potentially fatal cardiotoxicity and neurotoxicity at a level more than 2. Serum levels should be monitored throughout the perinatal period and should be taken 12 hours post-dose. Exam question right away. Okay, and lithium is excreted unchanged by the kidney. So with increasing gestation, plasma volume expansion, and increased GFR, it will reduce the lithium concentration and higher doses will be required to maintain a therapeutic level. The serum levels are highly sensitive to changes in the renal function and fluid balance to hyperemesis gravidarum. So hyperemesis, UTI, or preeclampsia may precipitate lithium toxicity wherever there is going to be any kind of renal impairment because it is excreted through kidneys. If there is any renal impairment, so yeah, things are going to be quite challenging. Okay, lithium toxicity can be there. All right. So in the intrapartum phase, it is very much important. If it is spontaneous labor or if it is a cesarean section or induction of labor, this chart is very important for exam. Okay, when we never had this, the chart or this talk article, so we used to read nice, the guideline on the, the postnatal, the mental health problems, and also there was a, the small chunk on the lithium. They were, they quite focused on lithium, but it was not this much beautiful. Okay, so be with me and do try to revise it with me so you won't forget it for your lifetime. Okay, so if it is a spontaneous labor, withhold lithium at onset of the labor. Okay. Of course, because it is spontaneous, so you don't know when a woman will come. Okay, so you will hold the lithium at the onset of labor. If it is cesarean section or induction, you will withhold lithium for 24 to 48 hours beforehand. Similarly, as low molecular weight heparin, right? Prophylactic as well as therapeutic. Then 12 hours after the last dose, you will have a blood's for renal function and lithium level. On the blood form, include the time of the last dose and the time of the sample was taken. Because if you will send it to the laboratory, so the laboratory, the person should know that what we are looking at properly. So he will give you proper report accordingly. So if there is evidence of renal impairment or lithium level is more than 1, what you will do? You will withhold lithium. You will maintain hydration. You will repeat bloods every 12 to 24 hours. And what you will be seeing in terms of lithium toxicity, weakness of the, woman will tell you that I'm feeling so tired or weak or, anything. Abnormal movements, jittery movement, jerky movements, confusion, hypotension, hypothermia, tachycardia, seizures, very, very severe form. So these signs you would be looking at, for the lithium toxicity. If it is more than 1, you will withhold and maintain hydration. You will repeat bloods after every 12 to 24 hours. If the functions are less than 1, you will restart lithium after delivery at the pre-pregnancy dose. Okay, at the pre-pregnancy dose. So once lithium is restarted, repeat lithium level and the renal function, number 1, after 5 days, then twice weekly until levels have been stabilized. Exam question. This was my exam question as well. Okay, that in the perinatal or the postnatal period, when are you going to do the lithium levels? Okay, and what is going to be the frequency, right? So if you have restarted the lithium, then you will do the lithium level and renal function as well after 5 days and then twice weekly until levels have stabilized. All right, clear this part, guys? Any question? Clear, everyone? Uh-huh. Okay. So no answer is also a good answer. It means it is clear, right? Repeat. Okay. So let me. Lithium. Lithium is what? Mood stabilizer. Okay, strong mood stabilizer. If a woman is on the lithium, you have to do the monthly checks, all right, in the antenatal period. If a woman is coming in labor, if it is spontaneous labor, you will withhold the lithium at onset, and then you will repeat the lithium levels after 12 hours. All right. For example, if a woman has had lithium, the dose in about, the 8 a.m. today, for example, okay. So after 12 hours, you will have the lithium levels and the renal function levels as well. Why renal functions? Because this lithium will be excreted unchanged through kidneys. If the levels are more than 1, you will withhold the lithium. You will maintain hydration. Hydration, why? Because the more the urine will be produced, the more the lithium will be excreted out. Right? You will maintain the hydration and you will repeat the bloods after every 12 to 24 hours. What a patient will be showing you in terms of lithium toxicity, weakness, jitteriness, all right, confusion, hypotension, hypothermia, tachycardia, and severe form seizures, right? If it is cesarean section or induction, you will withhold lithium 24 to 48 hours beforehand. If it is normal, then you will start lithium, you know, after delivery in the pre-pregnancy dose level. And then you will do the levels again, lithium and renal function after 5 days of the delivery. And then you will perform it twice weekly until levels have been stabilized in the body. Okay, Sadaf, clear now? Hmm? Mhm. Very good, Roma. Maida. Sadaf, is it clear to you? All right, great. Okay, so don't forget that this is a very important exam question. All right, brilliant, brilliant. So just remember the levels, okay, sweetheart? So levels have to be more than 1.0, okay, millimoles per liter and less than 1.0. This is going to be the normal, all right? Okay, so keep calm and study hard. This is what I always say, right? Because if you will enjoy your, the topics, if you will enjoy with full zeal and interest, of course, you are going to be okay and you will have interest to finish that topic. And me as a mentor and my team, along with my team, we have designed, certain workshops. So there is going to be a workshop series. So Talks workshop is starting from tomorrow. Then there is going to be exclusive only EMQs workshop because this is the hardest part where many students struggle. Okay, because I've been a candidate as well and I've been teaching for quite long now. So I know, the all of us, face some kind of challenge in solving the extended match questions, how to solve. So I will try my level best to give you some tips and tricks and then we'll solve questions with you. And then, we will do the recalls workshop as well. And of course, this December and January would be on full swing in terms of that we would be doing a lot of revision. Okay. So if anyone would like to, join me, because I'll be taking all these online sessions, unlike, the previously, we have been doing the discussion. So I think one-to-one or one-on-one discussion is very important. Okay, so we will be having some kind of the interaction with the students. Okay, and of course we will be discussing important talks. Okay, important talks means that I will be covering almost the 6 sessions. I will try my level best to cover the as much as possible. Roughly 50 to 60 talks will be covered in all these 6 days. So I think that is enough. Okay, if you study quite the nicely, and if you study with full the kind of throttle, so I'm sure it will help you. Okay, so the way I teach the is that I do try to focus on exam oriented topics and exam oriented lines and as well as the questions as well. Okay, so yes, you guys are welcome to join the any of the workshop, or if you guys want to enroll in all these 3 workshop, yes, you are more than welcome. Okay, and even if you want to the join the one workshop, you are more than welcome again. All right. So yeah, you guys will be there, inshallah, and I will see you guys. Yes, Sadaf, I will see you, inshallah. And the my other candidates as well. Noor is there, Rabia is there, and my other candidates, Saud is there. So yeah, we will be the meeting again tomorrow. So anyone would like to join, you guys are more than welcome. Okay. All right. So for lithium in the postpartum phase, lithium in the postpartum phase is going to be like you should be thinking of neonate, okay, neonatal considerations, because lithium exposure is associated with low APGAR score, lethargy, and feeding difficulties, resulting in an increased rate of neonatal admissions. Delivery should take place in a unit with the expertise to identify and manage neonatal lithium toxicity, and then, of course, breastfeeding. All right. Whenever we talk about postpartum phase, our our main concern is breastfeeding because everything will go into the neonate with the help of breastfeeding. All right. So current guidelines advise that breastfeeding is contraindicated in mothers taking lithium due to the risk of neonatal toxicity. There is emerging evidence, however, that term infants can be breastfed or mixed fed safely. But cabergoline should not be used to suppress the lactation as it can participate mania or psychosis. Exam question, right? That if a person is on cabergoline, you can't give her, if a person is on lithium, and if at all you have to give, the any kind of, the suppression, lactation suppression medication, so you shouldn't give this. All right. So this is important. Okay. So exam question. And the second exam question is that, it should not be given to any of the breastfeeding. Then it means, okay, to conclude it, let me tell you that breastfeeding is contraindicated with the lithium. Okay. And if you have to give any lactation suppressant, you will not give cabergoline. All right. So this was for lithium. So try memorizing lithium properly because one or two questions will definitely come from lithium, okay, itself alone. Okay, then if we talk about mood stabilizers, then we have just read earlier that anticonvulsants such as sodium valproate, carbamazepine, and lamotrigine or are, to be used as a mood stabilizer. But we all know that sodium valproate is highly teratogenic and it is contraindicated in anyone of the childbearing potential. Use in pregnancy is associated with 10% risk of neural tube and other congenital malformation and 30 to 40% of neurodevelopmental disorders. If someone becomes pregnant while taking valproate, so we will refer to urgent psychiatric review. In most circumstances, an alternative medication should be offered and valproate should be tapered off. Okay, never change, okay, because abrupt withdrawal is equally dangerous. All right. So you should not, the kind of change it or stop it altogether. You have to taper it off. High dose folic acid is not protective against major congenital malformation, but supplementation is recommended. Ultrasound screening should take place with fetal medicine service because sodium valproate is associated with what? It is associated with facial abnormalities, right? It is associated with cardiac defects, right? It is associated with cleft lip, cleft palate. It is associated with certain, the facial abnormalities as well, isn't it? So it should not be used at first place. If you don't have any choice, then talk to the woman, document everything in the record that, okay, we have spoken to the woman and we don't have any other choice. So yeah, we are going to use that. However, if we find any kind of, the abnormality, okay, on the, the woman who is on sodium valproate, for example, if she is a late booker or if we don't see her, and if on anomaly we do see any anomalies, then if the woman chooses to terminate the pregnancy, this would meet the criteria under clause E of the Abortion Act. Okay, so it is important that we will talk to her properly. Then early pregnancy exposure to carbamazepine is associated with dose-dependent increased risk of major congenital malformation, neural tube defects. Okay, and the low dose monotherapy is 4.5% rate of malformation. Background is 2 to 3%. Supplementation, we have just said that the for the carbamazepine, it should be from preconception and throughout the first trimester. Okay, because it may reduce the incidence of fetal malformation. Very important. Again, carbamazepine exposure is associated with performance IQ, intelligence quotient as well, right? So it is very much important that these children or these women should be taken care of quite closely. Carbamazepine is an enzyme inducer, isn't it? And it can interfere with the clotting pathways, while the risk of postpartum hemorrhage in exposed mothers may be marginally increased, and the current guidance does not recommend oral vitamin K supplementation. IM vitamin K at birth is recommended. This we do, by rule, all right, to prevent the baby from HDN. Carbamazepine interfere with the efficacy of CHC combined, the hormonal contraception and progesterone only pills. So women who are not exclusively breastfeeding should be offered alternative postnatal contraception. All right, very easy. Okay, just to conclude that we should not be using carbamazepine and valproate at first place, number one. If we don't have any choice, talk to the woman, talk to her caregiver, okay, and document in the record that, okay, we have spoken to the lady and we have, given all details, all right. And if at all that she has been exposed, then you have to do the detailed anomaly scan. If any abnormality, major congenital anomaly has been found on anomaly scan, you can offer her, termination of pregnancy as well. That would be under clause E. All right. And the third form of anti-epileptic, lamotrigine, okay, that usually the risk of congenital malformation exposed to lamotrigine monotherapy does not differ significantly from the background risk, because these days it's a choice, anti-epileptic choice for almost all epileptic women. Okay, the combined effects of hemodilution and increased drug clearance result in lamotrigine levels falling significantly in pregnancy. That's why usually we don't do the levels of anti-epileptic drugs. However, for lamotrigine we can do, because as long as plasma expansion will occur with the advancement of pregnancy, the lamotrigine level will fall. So we have to titrate the dose of the lamotrigine. Okay, we might need to increase the dose of lamotrigine in pregnancy. So, lamotrigine prescribed for psychiatric indications is commonly titrated based on clinical presentation, and there is lack of consensus on the role of serum lamotrigine monitoring in pregnancy for psychiatric indications. Therapeutic drug monitoring is not performed routinely, but may be clinically valuable, particularly when there are concerns about compliance or the presence of comorbidities such as renal failure, because this drug also is excreted through kidneys. Then women who required increased dose, they needs adjustment postnatally. Okay, failure to do so will result in lamotrigine toxicity, which will result in serious cutaneous reactions such as Stevens-Johnson syndrome. Then lamotrigine levels in breastfed infants reach approximately 30% of the maternal serum levels. However, breastfeeding during lamotrigine monotherapy is mostly considered safe. Skin rashes can be there to the infants. And if at all, we have to talk about the contraceptives. So estrogen-containing contraceptives is known to decrease the serum lamotrigine level. It will reduce the effectiveness. So alternative postnatal contraception should be offered. So generally speaking, we do not advise estrogen-containing hormones for the such women, okay? Because the chances of having DVT can be high, and postpartum itself is a vulnerable period to develop, for the development of DVT. And then if a woman is on certain form of medications, then the chances can be even more high. Okay. So this was all for mood stabilizer. Now we will talk about antipsychotic. Okay, so psychotic disorders including schizophrenia. Okay, so this woman is going to be a known case, right? Bipolar disorders and treatment-resistant depression. All right, so sometimes we do need rapid tranquilizers right? We do need them to sleep as quickly as early as possible, isn't it? So, we can give them relief. Okay, neurons can be at peace and ease as well. Most antipsychotic fall into two groups: first generation, FGAs, and second generation, SGAs. FGAs and SGAs. FGA is associated with anticholinergic side effects and extrapyramidal side effects such as dystonia, rigidity, and tremors. And SGA, second generation, will cause less severe neuromuscular side effects. They are more likely to cause weight gain and insulin resistance. So women who are taking all these antipsychotic prior to conception, this would usually be continued during pregnancy. There is an increasing evidence of safety in the perinatal period, and discontinuation is associated with relapse, self-neglect, and suicide. Okay, so long-acting depot injections are sometimes used in patients who have high risk of non-adherence. Depot formation are not associated with increased risk. All right. So having said that, again, let me be repetitive that for all these medications, combined hormonal contraceptives are not going to be preferred. Okay, oral, in fact. All right. So what you need to do is that you have to give somewhat, the depot injections, or you have to give implant, or you have to give copper IUCD or Mirena as well for the sake of contraception. So what are the first generations? Haloperidol, zuclopenthixol, flupentixol. All right. So what do they do? Dose related side effects, extrapyramidal. For all, the whole of our life, we used to be thinking about extrapyramidal side effects, extrapyramidal side effects. So these are tremors, dystonia, anticholinergic side effects, dry mouth, constipation, cardiovascular arrhythmia, orthostatic hypotension, neuroleptic malignant syndrome. Although it is very rare, but yes, it is fatal. Neonatal extrapyramidal side effects and low transfer into breast milk for most FGAs and SGAs, first generation and second generations. Okay, this is not small for gestational age. Okay, be extremely careful. So what you will do in all these things, because it can cause hyperprolactinemia, so you will measure prolactin levels if they are trying to conceive, because hyperprolactinemia itself is the dangerous for any woman who is trying to conceive, because it will impair the LH FSH secretion, isn't it? Then of course there are going to be problem if there is any kind of dose related adverse effect. You will do the immediate assessment and support with the ICU team and the psychiatry team as well. You will monitor newborn for the abnormal the movements or sedation. Encourage breastfeeding unless she is on clozapine. So clozapine, if somebody is on clozapine, so breastfeeding is contraindicated again. Okay, clozapine itself, olanzapine, quetiapine, risperidone, clozapine, these are all second generation, antipsychotics. So they are also associated with extrapyramidal, anticholinergic, and cardiovascular side effects. And having said that, clozapine itself is associated with increased risk of GDM and macrosomia. Okay, olanzapine, clozapine, and quetiapine. Basically, they say olanzapine and quetiapine. Okay, clozapine is reserved for treatment-resistant schizophrenia because it has a risk of agranulocytosis, hypersalivation, constipation, and myocarditis. Okay, so olanzapine, quetiapine will be associated with GDM and fetal macrosomia. So if it is, you will monitor weight gain and you will do the OGTT, serial growth scans. If it is clozapine, then yes, you will do what? You will monitor full blood count. All right. You will avoid opiates. You will monitor for the post-operative ileus. You will monitor newborns for the agranulocytosis. Advice against breastfeeding as well. Okay. So clozapine, usually we don't, the encourage the breastfeeding. All right. Clear everyone, this part, because this is very easy as well as, the good part of antipsychotic as well. Clear everyone? Any question? Mhm. All right, great. Okay, so what about all these antipsychotic? So if a woman is displaying any violent or aggressive behavior which poses risk to themselves or other, Because psychosis is what? Psychosis is extreme form of illness in which a woman might harm herself or newborn. Okay, the risk of suicide, the risk of infanticide will, they increase, isn't it? So what you will do in this scenario, you will inform or liaison with the psychiatry team, senior obstetrician, and midwife in charge. You will start non-pharmacological de-escalation. Plus, you will start pharmacological therapy. You will offer oral medication before, the perinatal, the administration. Aim for monotherapy where possible. Okay, so you might need to start with lorazepam, promethazine, haloperidol, olanzapine, okay, or aripiprazole, anything, okay, because you need to calm down the woman as quickly as possible. Okay, I'm sure we all are very well versed of, the lorazepam, diazepam, all right, in our, the low resource, the countries. However, we need to be very, careful that lorazepam might be associated with, the floppy baby syndrome and neonatal withdrawal, isn't it? Then promethazine, it is also to be used as what? It is used as anti, anti-sickness medication, okay, used in nausea vomiting, isn't it? Promethazine. Haloperidol, yes, it is what? It is our first generation antipsychotic. Olanzapine, second generation, and aripiprazole. It can also be there, okay, in this. So for exam, you don't need to memorize all these doses. However, need to understand that what you will do in terms of, the immediate therapy, right, to calm down her psychosis, and of course, to in which she's not going to harm herself or her baby. Then studies have controlled and confounders increase the congenital malformation in pregnancy exposures or with the, the first generation antipsychotic or second generation. Okay, so there is no increased risk of congenital malformation. Antipsychotics do not increase the risk of miscarriage. Long-term use of SGA is associated with metabolic syndrome, increased risk of obesity, diabetes, and hypertension. Olanzapine and quetiapine may be associated with GDM. We have just discussed, right? So, independent of diagnosis, GDM diagnosis, SGA have been associated with increased risk of fetal macrosomia, independent, right? So what you will do, you will, adopt a pragmatic approach. You will do OGTT, right? With consideration that you will do a earlier OGTT or home blood glucose monitoring. Okay, we call it as HBGM, right? If there is any coexisting risk factor as well. Plus, point to ponder is that it is not associated with neurodevelopmental problem. However, in the late pregnancy, it may be associated with any withdrawal syndrome, okay? It can be associated with any withdrawal syndrome in terms of that in which a baby will show restlessness, dystonia, tremor. Breastfeeding is contraindicated in patients with clozapine, okay? So from here, what we concluded that breastfeeding is contraindicated in lithium. Breastfeeding is contraindicated in women with clozapine, okay? Because it can put the baby at the risk of neonatal agranulocytosis. So we would be very mindful that, okay, we are not going to allow the woman to go for any breastfeeding. Most antipsychotics are associated with hyperprolactinemia and will not interfere with lactation, with the exception of aripiprazole, which can lower serum prolactin in the dose-related manner. And women taking antipsychotics other than clozapine should be supported for the breastfeeding if they wish to. All right, clear everyone? Antipsychotics. So we have discussed so far, the antidepressants, then mood stabilizers, and then antipsychotics. Now we are moving forward towards sedatives. Clear so far? Hmm? Okay, all right. All right. Now we will talk about sedatives, right? So sedatives, if we talk about sedatives, and we are much familiar with benzodiazepines, right? We are familiar with Z hypnotics. We are, familiar with first generation antihistamines as well. Benzodiazepine, long-acting diazepam, clonazepam, short-acting lorazepam, temazepam, right? So all these benzodiazepines are associated with floppy baby syndrome, exam question. and on neonatal withdrawal if prolonged use in the third trimester or if given around the time of delivery. So what you will do, you will consider tapering before delivery. You will have a close collaboration with psychiatric team. You may require inpatient admission as well. And it also has the minimal transfer into the breast milk. So what you will do, you will reassure the woman. You will monitor for the neonatal sedation, particularly if the baby is premature or if there is any complex needs or if there is any significant exposure antenatally or intrapartum. If there is any hypnotics, of course, the possible association with SGA and low birth weight baby, neonatal sedation, minimal transfer to breast milk. So what you will do, you will have a serial growth scans. You will reassure that okay, neonatal sedation is there, but it's not going to cause any harm. All first generation antihistamines, promethazine, diphenhydramine, because they are having anticholinergic side effects as well. Okay, like dry mouth, constipation, urine retention. So what you will do is that for the constipation, of course, you have to relieve the symptom. You will give these stimulant laxatives. Okay, and for the retention, you will be putting the indwelling catheters. All right, and indwelling catheter itself is a big topic. If someone has that, then we have to follow the complete the protocol. It can reduce prolactin secretion. So there can be impaired lactation in the early period. So you will give alternative sedative. All right. So having said that, if you have to give any sedative to the woman, so make sure that you are counseling in terms of their tolerance and dependence can be there. Okay. Although there can be minimal transfer into the breast milk, but yes, we need to look for the neonatal withdrawal syndrome, neonatal sedation as well. If baby is sleeping for quite long and for the long hours as well, then yes, you need to be very careful. Okay. Then sedatives are CNS depressants. Okay. So what are they doing actually? They used to treat the anxiety and the sleep-related disorders. The most frequently prescribed sedatives include benzodiazepine, non-benzodiazepine like Z hypnotics, some antihistamine, which we have just read. Okay, they can be associated with preterm birth, small for gestational age, neurodevelopmental problems, and prolonged use in the third trimester will be associated with poor neonatal adaptation either through CNS depressants effects or through neonatal withdrawal. Floppy baby syndrome, treatment flumazenil, exam question. Okay, so floppy baby syndrome will be caused by benzodiazepine. And how it is going to be reversed? It is going to be reversed by the antidote, which is flumazenil. Going into the detail is out of our, the syllabus, but yes, you should know that what are the drugs and what is the side effect and how you can reverse it. So lorazepam is often favored in lactating mothers owing to its shorter half-life and established safety profile. Breastfed infants should be monitored for sedation. In the context of prematurity and polypharmacy, co-sleeping should be discouraged. Co-sleeping means the mother and the neonate is sleeping together. Okay, if a woman is taking any sedating medication, this can increases the risk of having SIDS, sudden infant death syndrome. Okay, then zolpidem is another and the sedative. It's the best studied agent in the breastfeeding and hasn't been linked to adverse neonatal effects as well. All right. So although it is not much talked in this talk article, but clinically we do see that the many psychiatrists they do prefer this zolpidem as well. Then what about antihistamine? First generation, they can be over the counter. Okay. They can be given and they are not associated with any fatal effect, such as congenital malformation and all. Antihistamines can lower the basal prolactin secretion and interfere with the breastfeeding initiation as well. So it can also be there. All right. So this was all about this, the use of psychotropic medications in the perinatal period. If you guys have any questions, I'm here. You guys can ask me from anywhere. The take-home message for all of you should be that you will inquire in terms of history when a woman comes to you for the baseline, the mental health check, okay? Ask them at least, follow, stratified the risk, all right? If a patient is a known case, try putting her into the less, the problematic drug in the antenatal period and in the postnatal period as well. Try talking to them. Okay, tell them, educate them that pregnancy or the being a mother after delivery, this you are going to be experiencing. Okay, so just talk to them, just the alleviate their concerns, invite questions. Okay, trust me, when I did my MRCOG, my consultation has improved in terms of that. After every consultation, I do try to ask from my patients, do you have any question for me? Am I clear so far? Okay, so do adopt this, the strategy for you as well. Trust me. I hope the you are going to become a even more good clinician, whatever you are at the moment. All right. For mental health, try understanding that mental health is very important. Okay. Mental health disorders are very important. We can't overlook any mental health issue, even if it is an anxiety, even if it is, the milder form of depression, because all these things, if they are overlooked, then they can convert into severe form of illnesses as well. Okay, for this talk article, few things are important. You have to, the read lithium in detail. Okay, lithium use around the labor, which is important. You need to understand which type of, the antipsychotics are there, first generation, second generation. Okay, and what are you going to be using in terms of sedatives, and when are you going to use all these sedatives? Okay. So these are important, the questions. And one more important thing, that lithium and, the clozapine, they both are contraindicated for breastfeeding. Okay, so I think this should be your take home message. So still, if there is any question, please do ask. Mhm. No question. It means either it was so clear or either it was not clear. This I always say. Yeah. Mhm. It was clear. Thank you, Ritika. Good to see you. Ah, Roma, how are you? Okay, very good, very good, very good, very good. I'm happy that at least, the we could try to extract some of the important, the what I can say, the points which are important clinically as well as theoretically, isn't it? So still, if you guys have any question, any query, you guys can reach out to me. I'm the available. Thank you so much, Noor. Thank you so much. Okay, so I hope you guys can get the idea that mental health is very important. I chose this topic per se because I really feel that we need to talk more about it. Okay, so I think we people, you, me, and all of us, we are, the individuals who are dealing with the patients, all right, on day-to-day basis. So I think, keeping in the view of current circumstances, everybody is suffering at one or the other level, all right? So do talk to them, do try to alleviate their concerns, and especially the pregnancy, how pregnancy can changes the perception of the individual. And of course, the delivery and becoming mother itself can be overwhelming, isn't it? So do try to talk to your patients. Okay, do try to bring a change in your practice, and I hope inshallah you will be a good individual as well. In terms of exam, yes, I'm there, I'm trying to help as much as possible. Okay, with the lowest possible fee, because of course the I'm giving the time. So with the fee, what will happen is, although I they encourage free webinars quite often, right? And the people who know me, they know me that I conduct the free webinars quite often. All right, so I will be conducting till your January exam. Okay, maybe the fortnightly, every fortnightly or weekly. So I will see according to my schedule. But on the other hand, yes, the all these workshops are there, so you all are the more than welcome to join me. So we will be having the kind of what you can say, a good roller coaster of the revision. All right, we will start from tomorrow with the talks. We will kick off with the talks workshop, and then we will have 5 to 6 days break, and then we will do the uh, single best on oh no the extended match questions workshop, and then we will do the recalls workshop. All right. So by this, I will be together. I will be with you guys till your exam, and of course till you sail through. All right. So if you guys have any query, anything from your syllabus or anything, or if you want to know that how are you going to utilize your last 1.5 month before exam, so you are more than welcome to inquire, to send me message, to send me email or anything. Okay. I will try to answer with the best of my knowledge. All right. Thank you. Thank you so much for being there. Okay. So inshallah, I will conduct another webinar very soon. Okay, so I will be talking about how are we going to solve extended match questions. All right, so do try to attend that as well. Okay, and because I think that is very important, that how are we going to solve questions for exam and how we can maximize the chances of passing this exam. All right, and again, to conclude the session, never think that success is easy. Success comes after hard work and consistent work. Okay, so hard work and consistent work. So stay calm, stay focused, and be persistent. And nothing is impossible. All right. Maybe one day you will be teaching like me. Maybe one day you will be guiding other students like me. All right. So all the very best. Study, study hard, study smart. I will see you around, inshallah. Maybe after like the few days. Okay. So we will be talking for another topic. All right. If meanwhile, if you guys want another webinar, so you guys can suggest me any topic. All right. So I will try to conduct, the talk article, in fact, because I really love to talk about talk article. Because if you read talk article as a story, it will be imprinted in your mind. Trust me. Okay, and it will not go away. All right. So stay focused. Stay focused. That's it. And in the last 1.5 month, don't get the overwhelmed by the burden that that the syllabus is huge and I have not studied that much, and that girl or that student has studied that much, and I didn't do it. No, no, no. Never compare yourself with anyone. All right. You are unique, you are yourself. Okay, nobody can be you. You cannot be me, I cannot be you. All right. So choose your battles wisely, choose your the kind of study pattern wisely and smartly. In the last 1.5 months, stay focused and stay calm and take care of your health as well. All right. Inshallah, I will see you guys somewhere maybe after like few days. Okay. So I'll catch you up with the another interesting topic. All right. Till then, take care. Allah Hafiz and bye bye. Good night.